Good afternoon. I'm Dr. Perry, and welcome to First Friday Live for Positive Steps Fertility. I am excited to be here talking one of my favorite issues, which is tubal disease. We're going to talk about what can damage tubes, how do they work, what are the ways of repairing them, should you repair them, when do you do tubal reversal, when do you do tubal repair, when do you go on to IVF, all the issues around that. And as always, for all these things, remember to connect with a clinician to see if medical knowledge has evolved or if it applies to you personally. And also type in all your questions, and we will also answer anything we can along the way for things. So the first thing is, what are the tubes? I mean, why do you need them? I have people all the time saying, oh my gosh, my tubes are tied or they're damaged. Can I get pregnant even if I bypass them with IVF? So you don't need the tubes to be pregnant. You can have people fully remove the tubes and they can still get pregnant through IVF and a few other approaches. However, morning, Tricia, good to see you. The thing for the tubes is the tubes, even though everyone knows that the pregnancy occurs within the uterus and the uterus grows over the course of the pregnancy, the first fertilization or the conception or the development of an embryo doesn't start out actually in the uterus. The sperm and egg find each other in the tubes in the moment of fertilization, and those first 5 days of growth and development are really within the fallopian tube. And so what happens actually is that when people have relations, sperm is placed within the vagina or again directly in the uterus through insemination. Just having to put out the shout outs and love to people joining in. You then end up having the sperm swim up into the uterus along the cervix, and then they end up swimming into the tube. Hey, Tori, good to see you. Thank you for joining. You have it then preferentially swim up into the tube to where it will find the egg. And so everyone, I always say, thinks that the tube is this magical slide and sperm are on one side and the eggs on the other and they just shoot together. That's not at all how it works. What happens is there are little hairs that are within the tube that push the sperm and egg together, and then they eventually find each other. And so they preferentially swim up the side where the hairs are activated from where the egg has been released. And then once sperm and egg have fused, and it's around day 3, and this is actually where you see hey Joel, hey Allison, you see that sperm and egg have joined each other, and you see the rise in progesterone. The hairs change direction, and they push the embryo back down to the uterus. I always say to people, the sperm have a tail, they can swim, but the egg doesn't have a tail, it can't swim. The embryo doesn't have a tail, it can't swim. So the tube is not just a pipe. It's more like a pipe with a pump. It can push things in the direction it needs to be at the right time. And the reason that matters is it's not just whether the pipe is technically open, it has to be moving things properly. And so if the tube can't push things to where they need to be, then they don't get here. And just for a picture of that, and just for where things are. So this is Netter. Let's see, picking up a little bit higher here. Let me adjust the camera for a second. So you can see a little bit of the uterus and tube and ovary right here. And the uterus, again, is on, I'm seeing on the left of the screen, but we'll have to see, but I can reverse myself here for a second. But anyway, the uterus has the space, and I'm trying to hold this all open. Apologize for that. The uterus is right here. The sperm come up here through the cervix into the uterus, and then they travel out through the tube here, and then the egg comes conversely down along here, and they meet in this portion. And that top, slightly wider portion is called the ampulla. And that's where fertilization usually occurs. There is a narrower portion before you get there, where you get to that part on the tube. And that right here, this is called the isthmus. And this is, so between this area and here is where a lot of damage occurs for when people have pelvic inflammatory disease. And it makes it so that usually if you have an ectopic pregnancy, it's occurring out here, which is called the ampulla. About 70% occur here, and another 10 to 20% occur here in the isthmus. And that also, the reason I'm pointing those out is because those are often the areas that you have to repair if you have issues for things. Hi, Shelley. If you have a tubal ligation, they're usually doing it in the ampulla. If you have an ectopic, it's usually in the ampulla. But also, if you have a tubal ligation that gets into the isthmus, the ampulla is really wide. It can be about this wide, while the isthmus is much more narrow. And the reason that matters is if you're trying to repair it and you take a small area and put it to a really big area, you have to stretch it out or adjust it when you're trying to do the repair. And sometimes that makes for less effective repairs. Now, again, when the sperm and egg are in those areas and there's ciliary damage, so damage to the hairs within the tube, the sperm and egg can't get to each other very easily. And that's what leads to your ectopic pregnancies, which is a pregnancy inside the tube. As I said before, again, the sperm have a tail and can swim, but the egg doesn't have a tail, it can't swim. The embryo doesn't have a tail, it can't swim. So to get where you need to be and have things find each other, you've got to have that active pump, or really for the pipe. These are the hairs that push the two together, and then ultimately reversing things for the direction and get things back to the uterus. Now the question is, and we'll talk about both for hydrosalpinx, so damaged tube, often after pelvic inflammatory disease, but can be endometriosis, other things. If you have it damaged, can you repair it? And I'm just going to do a quick shout out here for things. Hey, Brandy. Hey, Shelley. Love to see you guys. And hey, Meredith. So the number one thing everyone says is, do you repair it? Now, I have to have slides, and I'm going to do more slides for the future. I've got a few for today. And so the thing is, it says, do you fix an internally damaged tube? And what it shows is down here on the bottom, if I can get there, is that you actually have, if it's a minimally damaged tube, here we go, I can see it better this way. For pregnancy rates, you can actually have some decent repair for things. And this is showing that over a 3-year period, about 30% of people can get pregnant if it's internally damaged. And if it's a little bit more damaged, they're showing about 20%. But if it starts being much more damaged, you're talking 10% or even 5% over several years. So the statistic is that, at least that was in this study, and this was in the Annals of New York Academy of Sciences, do you repair a damaged tube, which is called the hydrosalpinx? And the reason that matters also, by the way, they accumulate toxic fluid which leaks into the uterus. If you do IVF and you bypass a damaged tube, the toxic fluid that pools in there, even if it's technically open, it can leak into the uterus and it kills 2/3 of pregnancies. So we really care about these. And so let's say you're able to repair it and get rid of the hydrosalpinx. If you look at the most damaged tubes, or really all of those, half of those pregnancies, the 30%, 20%, 10%, those were all actually, half were miscarriages or ectopics. And so really you are looking at the 15% to 5% take-home baby rates, depending on how bad it is. And so a lot of people say, if you have a really bad, some people will say that with repair, you can have a 20% to 25% take-home baby rate over 2 to 3 years. Most of the people, by the way, get pregnant within the first year if it's going to work. So if you had a tube that was damaged and you didn't get pregnant within the first year, the likelihood that it's working after that isn't exactly where you want it to be. And if it's really damaged, and you say that you have about 1/3 the success if it's really damaged, or 1/3 the success if you had gonorrhea or chlamydia for an infection. And by the way, for the things, and so you can even see people getting the 2% or 6% chance with badly damaged tube of bringing home a baby over several years. Why do I bring up the gonorrhea and chlamydia? So here's the thing. First of all, there are a lot of If you have been a tubal damage, don't think oh my gosh, it must have been an STD. I don't want people blaming each other or finding fault. That's definitely not the case. However, we here in the South are kind of the epicenter for really bad infections for things. So Alaska is number one, but that's a lot of men for things. If you look at number one in the country for chlamydia, or number two in the country after Alaska, it ends up being for states, it ends up being Louisiana, and Mississippi is number three for chlamydia. And if you look at number one for gonorrhea, it's Mississippi. And so there are a lot of STDs and infections down this way, and that leads to a lot of damaged tubes. In fact, for chlamydia, a single case of chlamydia can lead to as high as a 20% chronic pelvic pain rate and a 20% chance of tubal factor infertility. So if you've had chlamydia in the past and are having trouble getting pregnant, it can be even much higher than that. You want to get this looked at. And the reason the tubes matter so much, again, is you can have fantastic sperm, you can have fantastic eggs, a perfect uterus. But if the sperm and egg can't find each other, that explains a lot as to why things aren't happening. In fact, for our experience, the number one reason for not getting pregnant here in the South for the patients we see, it ends up being a degree of tubal damage. And so you definitely want to have that worked up and evaluated. And we, again, do the testing in the office with the periscope approach for assessing tubal patency, as well as ovarian and uterine factor. But there are other things like HSG and sonosalpingography. The hysterosalpingograms often hurt like heck. But that's one approach. The sonosalpingography is air-infused saline viewed by ultrasound. That can hurt as well, but and it also takes some expertise to get it right. For the periscope technique, for looking at things where you infuse things at hysteroscopy, that's gentle for most people. And a lot of the people who do have discomfort, you can predict in advance and help reduce that risk, but that's a whole nother topic. In fact, I'm planning to do that at another time. But as long as you have the right equipment and the right hands, it can be a lot more gentle than what many go through with office hysteroscopy or HSG. And that's topic for another day, but and a favorite topic as well. I look forward to doing that one. Hey, Tracy. Hey, Chastity, Stacy, Mandy, all kinds of good people coming on here. Lots of love, by the way, for everyone here. Hey, Rachel. Hey, Jeanette, so great question, by the way, on our gonorrhea and chlamydia, the only two STDs that lead to infection and blocked tubes. And so first of all, I would say nothing is 100%. The body doesn't always read the book. And the second is there can be some vaginitis. You can see actually some variations on bacteria in the pelvis. Everyone thinks that the vagina has bacteria, about 15 different types of bacteria on average, and sometimes they get in the uterus. We used to think that it was only STDs that went to the uterus. Now we're not so sure, and there can be chronic endometritis. Gonorrhea and chlamydia are the ones that are most classically associated with it, but I think our knowledge and understanding is evolving, and there may be more. I think for many people, they should have uterine evaluation that includes office hysteroscopy relative to just plain ultrasound, HSG, or saline infusion sonography to better understand the pelvis. And sometimes we can find things that reflect it. But certainly I would say that gonorrhea and chlamydia are the top two infections and the ones that are STD more that you have to watch out for the most, at least for focusing on it. That's a great question for things. Hey, Brittany. So yes, we do watch out for those most. The next question for people is, so you try to repair things, but you also recognize if you do surgery to try to salvage the tube, it may not work. And again, if you end up, the person who has a 20-25% chance over several years, granted, that's a bit slower than some like, but that might be the right fit for some people. If you're at a 2% chance over several years with a high likelihood that the tube closes up, doesn't work, and then you need repeat surgery to either remove the tube. I'm not a huge fan of repeated surgeries to operate on the tube. Not that it can't work, but it becomes less probable. And that's something where some people just say, let's get it done and get it out for a dilated, damaged tube. and then move on to IVF to bypass the tubes. And people debate on the success rates for IVF, and I think a lot of people are throwing in data where people have an unsuccessful lab. I think you need to have programs with really high success rates. I'm very proud of our program for things. I think that makes a very big difference in talking about things depending on your options. And again, if you don't have good options for IVF, sometimes tubal repair is better, but I think the better answer is to go to a place that does have good success rates. The other thing people ask about is, well, does tubal disease lead to better outcomes? In our personal experience, we often find these are better prognosis people once you've addressed any hydrosalpinx, which again is the dilated damaged tube. And the reason is, if you aren't getting pregnant because of a damaged tube, it's that sperm and egg can't find each other. It's not that you have bad sperm or bad eggs. They just haven't been meeting. We find those people to often have higher pregnancy rates than those where sperm and egg have met forever, and they were bad sperm or bad eggs, and then things weren't likely to take because the DNA building blocks just weren't as good relative to people where they just haven't had an opportunity. And so this is often very encouraging when you find tubal disease. You hate it that you have to bypass the tube sometimes and do something high tech, but you're really happy that at least you're a good prognosis once you have the right building blocks meet each other. Now, the other thing is, what is the success rate for tubal reversal? Because again, tubal reversal is very different in some ways from a hydrosalpinx. The reason is that you do have a damaged tube, but instead of potentially being the full length of the tube, it's a focal point. Now, there are a lot of things you have to think about when you're having a tubal reversal. You want to think, okay, first, how old is the patient? For instance, if you were really, really fertile at 23, that doesn't mean you'll necessarily be fertile at 43. Things can have changed beyond just the tubes. And so you do have to look at the age of people. So people go back and forth over the numbers. Some people say 35. You just start leaning more towards IVF for things. Not everyone agrees with that statistic, but I think the reason is, again, many people get pregnant within 9 months, but some people are watching the amount of time it takes for things. In fact, some people argue that a lot of the people get pregnant from tubal reversal within the first 3 to 6 months. If you go beyond that, you definitely want to have your tubes looked at, because especially if you're getting older and time is running out for the egg, so to speak, that biologic clock is ticking, and sperm and egg aren't finding each other at all, that's a bad thing. So we had a person just the other day who was told at the reversal that her left tube looked gorgeous for things at the reversal, and the right tube, not so much. When we went in with a hysteroscopy and we're looking at patency, the right tube was wide open, but we saw the left had actually had the whole lining of the uterus and everything overgrow it as though it had never been there. So even though at the point that they fixed the tube may have been fine, the uterus had ended up ultimately healing in a way that there wasn't access to the remainder of the tube. So there can be things that happen, but you look at the age of the person, you look at how many children they had, also as a proxy for fertility. You look at how much of the tube was taken out, and the more the tube, the better the chances. If you have an area that's sort of like this, which you're connecting, let's say, trying to get within the frame, you might have some space. But if you have this tiny little thing and you have the tube really on strain to come back together when you reassemble it, you're using really small stitches for this. I've used 8-0 suture in the past for this. 8-0 is half or a third the diameter of a human hair. And so if you have a really short length and a lot of strain and tension on it, it can pull through things. So it's sort of like how piano wire can cut through things very easily. So you don't want too much strain on it. If there's a lot of tension, you just lose what looks good at the surgery, but doesn't look so good afterwards. The other thing that they look at is what type of tubal ligation was it. Clips and ring tend to do better than if you had sort of the excision, or where they took out a whole loop and they had the things close together, or they took out separate intervals and there's a gap between them. These are called Pomeroy and Parkland types of tubal ligations. There are other more complex ones, but those are the two most common. Um, so that's very important. The other thing was cautery use. So did they burn it? And I think one of the things some people remember is, was there a burning sound or a smell at the time they were doing the tubal ligation? And one of the things when you're talking with your doctor about whether to put tubes back together, you want to ask, hey, did they end up was it a postpartum tubal, or was it after you delivered by 4 to 6 weeks? That's something basic that most people remember, and that gives an idea of what was probably done. Getting the op report and even a pathology report, if there is one, also helps in talking to the doctor. So if you can get that from where you had a tubal ligation, that matters. But the other thing that nobody really talks about that much, by the way, just checking on comments here for things. Hey, Charlene, well, I am so glad for you that you were successful. And again, some people say 9 months is the average, but I think that's looking at data. So I actually have some data about to pull up right here for things, looking at who gets pregnant and how fast. And the interesting thing is, so you can see here for the pregnancy rates. This was one of the largest studies ever done by a person who's an expert in tubal reversal, one of the best in the world, arguably. And there was about 75% pregnancy rate this is for women under 35, by the way. 75% pregnant with a clip, 72% with ring, 66% if it was burnt, 63% if it was ligation or they cut it away, and only 54% for sort of other or complex ones. But here's the thing that most people don't talk about. Half of these were miscarriage or ectopic. And so ultimately, only half of these numbers brought home a baby. So for under 35, with clip, it was 37% bringing home a baby, ring 36%, coagulation 33%, ligation resection 31, 32%, and other unknown 27%. That was my understanding from what I've read from the study for things. And I think that's really important, because one of the things to keep in mind is, while you want expert hands, the number one thing is not, can I get it done, but dollars spent per pregnancy achieved, what's my likelihood of bringing home a baby? And if you are getting a 31% for being under 35, if you had just regular ligation or resection, which is the most common way I see, that means there's almost a 70% chance you won't be successful. And if you are under 35 and going to a practice where your cumulative live birth rate is, in the close to 80% or higher, that means with tubal reversal, you might have a 70% chance of failure relative to a 20% chance of failure with IVF. Now, IVF can be more expensive, and it depends on how it's done, but often even with miniature stim, where you just get fewer eggs, the success or take-home baby rates can be comparable to, if not better than that, as reversal for comparable cost. So one of the important things to talk with the doc is dollars spent per pregnancy achieved. Where is my value and what are the options? And you want someone who gives all the options for things. So let's look down here for a second. Hey, Whitney. Hey, Stephanie. Yes, Stephanie, that is an awesome question for what about block tubes. That's earlier on in what I was saying for things. Definitely rewind. I can tell you a ton of that. I'm happy to do in person as well. Hi, Kim. Hi, Patsy. The Hulk clip for Charlene, yep, again, that's the one where, again, we were saying that is the single highest success rate, and you're just barely at 35, so that's a good thing. Hey, Kim, we love you too. You're awesome. So these are all really, really good questions. Hey, Brittany. So I think one of the things that I really emphasize for people is the economics. Dollars spent per pregnancy achieved. Everyone is always thinking, oh, if I just do it, I was fertile before, I will be fertile after. And that isn't always the case. You also want to make sure there's nothing else going on. By the way, the single most important thing that I have not said and that I have to emphasize is make sure the guy gets a sperm count. It is amazing how many people will do a tubal reversal without ever checking out the guy. Um, and the reason is everyone thinks, oh, the woman's had 4 kids. The guy, the new husband, then has never had any children. They want to get things reversed so that the guy can have a child. And the reason he doesn't have any kids is in any previous relationship is he's been firing blanks. And there's no other delicate, well, there are more delicate ways of putting it, but that's the important point. Make sure he has things, because it would be very silly to do all this work to take care of the woman and then find ultimately there's no sperm to find an egg. So I think that's a really important thing. Hey, Stephanie. Okay, great. Looking forward to it. Hey, Jenna. 38 years old DOR with blocked tubes. Do you recommend removal before IVF? Great question. And again, very individual, and you have to know the details for it. So the thing is, if the tubes are damaged, a dilated damaged tube for hydrosalpinx that drops live birth rates 2/3, 3, you can argue the numbers for it, but it is a very meaningful reduction in live birth rate before IVF if the tube has a hydrosalpinx. However, if it is just simply blocked, but not having that toxic fluid accumulation, it doesn't seem to have a clear negative effect on IVF. So if it were, I think from my saying, everyone asks, what would you do for your wife in this situation? If the tubes are not having a negative effect, it adds cost, it adds risk to do surgery. I think if it isn't detracting, I would lean away from removal. But at the same time, with diminished ovarian reserve, the one thing everyone has to talk about is how many eggs you get. Nobody mentions this, but at 38, often 2/3 to 3/4 of eggs are chromosomally abnormal. So if you have diminished ovarian reserve, you have 4 eggs, hypothetically. That means you might only get 1 that's normal, and then that might not be the right sperm. It might not be the right time for implantation. What people have to know about for IVF is that you have to do the right thing for the right person. And the person who gets 4 eggs is very different from the person who gets 25 eggs. 4 eggs might give you 1 chance to get pregnant, while 25 eggs might give you 6. And so you have to individualize it and customize it. Some people where there's diminished ovarian reserve may be better candidates for tubal repair than for IVF, because ultimately they'll only get 2-3 eggs with IVF relative to doing 2 to 3 eggs with oral medication. But that's a very complex discussion and has to, like all these things, as I said before, it has to be individualized. Medical knowledge can evolve. Talk with me, talk with your clinician about where the best balance of safety and success is for you. Let me just see if there are any other questions. Hey, Brittany, I'm looking forward to it. I appreciate all of you tuning in. I feel there was much more I was going to discuss, and somehow it has slipped my mind. But if you guys post and send your questions this way, I am happy to tackle anything at any time for these. I feel sometimes I'm repeating myself, so please send me questions. I'll do new videos on the topics that all of you feel relevant. Good luck for wherever you are in this journey, and don't go it alone. Get support. And if you know others who are suffering in silence, support them, pay it forward, and may you and everyone you get the family of your dreams. Thank you so much.